focusing on building a platform for emerging voices in the HTAi community. So let me introduce you to Yanga.
Hello everyone, my name is Yanga Nokepei and I am from Cape Town, South Africa. I am with Insight Health Solutions and I've been a member of HTAi for more than 5 years now. I'm here to introduce to you our plenary session 1, which is titled NextGen HTA, Embracing Change to Meet Global Demands.
Welcome everybody to the plenary one. My name is Andrés Pichon Riviere. I am one of the co-chairs of the ISPC and the director of the Institute for Clinical Effectiveness and Health Policies, the local host institution of the meeting. And I'm really very happy to chair this first plenary here in Buenos Aires with my friend and colleague, Baya Ordwin.
Thank you so much, Andres. So yes, my name is Baya Ordwin. I'm from the Netherlands. I'm the past president of HTAi, currently still at the board. I'm also senior lecturer at Radboud University, and I'm also the chair of the deliberative committee in the Netherlands, and it's my honor and pleasure to be here and to moderate this together with Andres.
And our idea in this plenary, and we hope that you will participate, now we will explain how, is to explore about the role and the future of HTA.
Yes, so actually this plenary is building upon the plenary session that was held last year in Seville, where we had a keynote speaker that clearly challenged us to rethink the role of HTA that we are currently playing. And the question that was really or stand out at that session was, could HTA evolve from being a gatekeeper, focused on more incremental assessments of individual technologies, more as becoming a shaper of health systems? So the question that we have on the screen is I don't know, can you go to the next slide, or I have to go to that on the next slide, I think. Yeah, so actually this is the key question that we would like to start with. So this is the key question that we are going to address in this session. And we want to have a dialogue. So it's not about opposing views in favor of this question or against this question, but really, can we make a change? And if so, or if there is a need to change, how can we move from a gatekeeper perspective to a more health system shaper? So that is actually what we want to do. But before we do that, we also would like to have a poll with you. And looking at Denise, can you maybe bring up the first poll, which is for which we would like you to hear your vote. So in your country or context, how relevant is this debate? How relevant is the debate on HTA role from gatekeeper to health system shaper? Do people see this on the polling in the app, I guess? Yes? Okay, so we would like to... No, it's not yet there? Okay. It works? Super. So we would like to hear your views on that. So please, all of you vote. We are not going to share the results yet, but we will ask you the same question at the end of the session, and then we will see whether or not your views might have been changed, also in relation to what our eminent panel will bring forward to us. So thank you for that. So I guess you can.
Well, while you continue voting, we are going to start with the plenary. Today, the plenary will be around that question. I think I can change the slide now, no? Mm-hmm. Yes. We are going to discuss around this question. Should HTA move from its traditional role to become a health system shaper? And we will hear arguments from our speakers and also from you in favor or against this proposition.
So before we start with the asking the panel to reflect, Andres and myself will give a kind of statement on the position. So it not necessarily means that it's our viewpoint, but we thought it would be good to give a kind of reflection on what we mean by HTA as a health system shaper, or how HTA could look like, still focusing on, say, more the incremental assessment of individual technologies. So would you like to start with your reflection?
Yes, just thinking before that we are joined here in the stage with two early career researchers that will help us navigate your comments, the comments that you will provide by the app. I would like to present Annapurna Prakash. Is a PhD student at Radboud University Medical Center and former high-tap researcher. Thanks, Anna. And also Carla Colassi. Carla Colassi is a medical doctor and researcher at the Institute of Clinical Effectiveness and Health Policy. So they will be receiving your comments. You don't need to wait until the next part of the plenary. You can start sending comments, ideas, and examples now. So, can I begin?
Yes, you can begin.
Thank you, Bayan. So, let me begin by offering one argument in favor of answering yes to our question. And I will use the example of infant mortality. Today, in high-income countries, infant mortality is around 4 deaths per 1,000 births. And for the sake of this example, let's assume that these 4 deaths are unavoidable because are the result of rare conditions for which there are currently no effective treatments, okay? I know this assumption simplifies reality, of course, and I will return to this later. But under this assumption, it makes sense, under this assumption, it makes sense that HTA would focus on evaluating new, often expensive technologies that are designed to treat those rare, hard-to-address conditions, okay? But now, let's turn to low and middle-income countries. These same 4 deaths also occur in low and middle-income countries, are caused by the same rare and currently untreatable conditions, and just like in high-income countries, low and middle-income countries are being offered and expected to assess and to cover those same costly cutting-edge technologies. So HTA agencies in low and middle-income countries should also assess these interventions. The problem, and here is the difference, sorry. Here's the big difference. In low and middle-income countries, there are not just 4 deaths per 1,000. There are 30. This means 26 additional deaths that are preventable because they are due to conditions for which we have effective treatments to provide. So it is clear in this example that focusing HTA mainly on the incremental analysis of new technologies maybe is not enough to bring meaningful change in health systems. And I would argue that this doesn't just apply to low and middle-income countries. Even in high-income countries, we see persistent gaps in prevention, in chronic disease detection and management, suboptimal results in cancer and mental health care. In high-income countries, millions still lack access to effective and affordable services. So HTA is a powerful tool, but could it be used more ambitiously? Maybe HTA should focus more on improving the implementation of interventions we already know are effective, rather than concentrating mainly on identifying and evaluating new technologies that might be effective. But of course, this is easy to say, and maybe it's not realistic. Let's see what happens.
Okay, thank you so much, Andres. So please, if you feel the same or have the same opinion as Andres, and you do have examples or reflections, please put those in the app, because that's what indeed our youth panel is going to collect. And we will also give you the floor later on during this session to maybe share those examples with us. So we would like to learn from you and have this dialogue. But before we move to that, and we will also ask our panel, I would give my viewpoints on the other, well, not the other side, but the other end of the continuum, which is more focusing on the incremental assessment of individual technologies. Because I agree that HTA must evolve. I think we also have heard that during the opening session this morning, that there are many challenges that are coming towards us. But I also think that we should primarily continue fulfilling the current function of HTA, because HTA is aimed to inform decision-making by determining the value of health technologies. And of course, you can think about health technologies as individual health technologies, but also more as, I would say, health system shaping. And we should do that by using the latest state-of-art methods as well as relevant evidence. And I think there we do have a very important role still to fulfill. It means that HTA should evolve in response to, indeed, all the scientific advantages that also Bogi was talking about, like gene therapies, digital health technologies, changes in societal preferences like climate change, methodological developments that we do hear about with regard to, for example, the use of AI in HTA, but also the challenging political context. Very important that we need to be attentive of this as HTA, and we are indeed at very challenging times. I also see from my own research and experience that HTA is struggling with regard to how do we assess, for example, new technologies or even existing technologies like medical devices. And that's a very hot topic around the globe, not only in Europe, although we are focusing with regard to the new HTA regulation on new medical devices that are mandatory from next year on to do joint clinical assessment. We still are using methods that are fit for purpose with regard to HTA for pharmaceuticals, meaning that we are not applying appropriate methodologies yet. We also see that there is consensus about using different kind of evidence, or at least a consensus that we should consider using different kinds of evidence like real-world data and real-world evidence. But we do have some challenges in capturing that in our current processes. The same with regard to the broader value elements like organizational aspects, for example, that really apply to assessing medical devices. And also, how do we capture the viewpoints of different stakeholders in HTA? We are talking a lot about participatory HTA, but we still do not have appropriate methods for doing that, or we might not apply them in the best possible way. So despite the recognized need for changes, I think we still lack a lot of appropriate methods. That's why I have this slide here. I think it is not yet fit for purpose, so we also need to be very attentive of this. I think also what we have seen also in research is that the scope of an assessment is often predetermined by the legal mandate or the legal requirements or the existing HTA guidelines. So even though there is a will to change, we are not changing because we are bound by guidelines or we are bound by regulatory as well as legal requirements. So I think it's very important to acknowledge as well that HTA agencies globally are understaffed. There is a huge pressure upon HTA agencies. So we also should take that into account before we move to broaden our scope to health system shaping. So I would say that the HTA is currently under high pressure. All kinds of developments are ongoing. So my viewpoint is that before we move on to broaden our scope, we should do our current function effectively and efficiently. So thank you for that.
So, thank you very much, and let's now introduce our distinguished panelists that will argue now in the first round in support of the proposition that maybe HTA should evolve into a health system shaper. We have Saudamini Dabak and Anna Basan. Later, I think you all know them very well, but they will introduce themselves just now. On the other side of the ring.
Yeah, we have Myron Ryan in pink, in beautiful pink. So give an applause to her because I really admire your dress. As well as, you know, we also have beautiful blue-suited Christoph Glaetzer on the other side. So thank you so much. Also, and as well, of course, to Saudamini and to Anna. You are beautiful too, so also an applause for them. Okay, so I think we start with Saudamini. So please take your time and give your viewpoints on the health system shaping. Thank you.
Thank you so much, Vaya and Andres. And good morning, everyone. My name is Saudamini. I'm from HTAp in Thailand. It's a country in Southeast Asia, for those unfamiliar. And today, very excited to be here in this beautiful city of Buenos Aires with all of you and this very esteemed colleagues of panelists here on the dais who are wonderfully here to represent different views. So let's take a step back and think about why we are here and talking about this issue. Countries around the world have committed to achieving universal health coverage. And health technology assessment has been identified as one of the ways for us to get there. But our countries are quite different. We have different health systems, structures, resources, and also are shaped by different values. And so we are also at different points in our trajectories of getting to this goal of universal health coverage. This means that, as Andres pointed out, HTA needs to be nimble and adaptive in order to respond in a meaningful way to the needs of different health systems. In Thailand, for example, we not only use HTA to inform whether a new or existing technology or intervention is included in the benefits package, but also how it can be incorporated in the benefits package or in the health system. We've used the principles of HTA to design or see the feasibility of implementing a screening program for children by school teachers. More recently, we've also conducted a developmental evaluation of a program by the government to extend access to the beneficiaries of the largest public health insurance scheme in Thailand to be able to reach and use services at any health facility in the country. For those of you familiar with the system, it's quite a dramatic change. And they wanted to learn and see how from this pilot phase, what mistakes are we making, what can we learn, and what can we do better as we scale up at the national level. And HTA has a role in some way to contribute to that discussion. This brings us and underscores the other point that we really need to be policy relevant. And we've heard this morning about many trends that are shaping and dramatically changing our society at the national and international level. Whether it is precision medicine, digital health, artificial intelligence, big data, or other trends that are emerging, we need to be able to be one step ahead and not just be on the sidelines. This might involve, as said before, creating or having some methodological innovations. But it also needs us to think about what processes and guidance can we provide so that the system, as we heard earlier, can be ready to be able to take up these technologies in an effective manner. We heard this morning about the importance of the rise of non-communicable diseases and the importance of health promotion and disease prevention. And health technology assessments agencies around the world are now also taking up this mantle and seeing how we can respond using the toolbox available to us. Now, this is also to say that we cannot do everything on our own. We each have a role in the system, and we each need to be able to draw on our relative strengths to be able to contribute and be able to move forward. Whether we are HTA agencies, academics, global bodies or global platforms, we each need to find a way to find and build trust, as we talked about this morning, and also increase solidarity. Here in Latin America, we know we have regional networks like Redetsa. In Asia, we have HTA Link. Global platforms like HTAi and global bodies like the WHO are now more important than ever in many ways to be able to bring together and provide a vision for us so that we can shape the way forward. So as HTA champions in this room, we hope you will hear Anna and Andres' call to really help and shape forward the HTA for the new era. Over to you, Anna.
Thank you, thank you. Is that, you can hear me? That was, first of all, I agree with everything that was said. I hope this is clear. Just to introduce myself, I'm the head of the Unit of Economic Evaluation and Analysis at WHO. I'm also Professor of Health Economics. I've recently taken the post at WHO since September and landed at a really good moment. I am officially the lead of HTA at WHO. I actually was a bit perplexed by this discussion, though I fully support and I love the topic. I think we don't need to win this argument because I think we've already won. And what I will say to that is actually if we go back, and we had this future sort of talk earlier, but actually we have to go back to the future in some ways, because in 1993, the World Development Report, faced with a similar economic crisis and a crisis in development assistance, wrote a report defining an essential package of services, considering cost effectiveness, equity, the first estimates of burden of disease. It was there. Now, maybe we can say there was a difference in the way the world responded, but in the early 90s, we all understood that we needed to prioritize healthcare at the same time, and we all adopted the same criteria, slightly different procedures, different measures. So we're doing it. It was just in that some countries, the question was really sectoral. And why is it that in some countries? Well, we know in low-income countries today, of public spend, there's $9 per capita. It comes to about $20 when we include the expenditures which are provided by development assistance. But they are being cut. We're going to lose 40% of that. That's a massive change in the system. Now, if we look at the way we define essential packages, we're only talking, in some cases, of 61 interventions. We are not talking about thousands and thousands of interventions, but how we select those 61 interventions is hugely important. We estimate that about 30 or 40% of improvement can come from these kind of efficiency gains alone. And these are highly efficient services. This will save millions of lives. So I'm not talking about a question of either or. I'm talking of a moral imperative to actually look at the way we allocate resources in low-income settings. So I've made, hopefully that's a convincing argument. What I will also say is it has been confusing for WHO, and I have been involved in the past, that we haven't quite understood how to bring different communities together. In 2021, we tried to develop methods and principles to guide prioritization globally. We brought together people who are working in HTA with other communities who are working in priority setting in those environments for a number of years. And actually, interestingly enough, we came out with this kind of conclusion that HTA was the guiding frame. And if you look at our documentation, we are saying that very, very clearly. But for us, it's how you define HTA, whether you keep it to technologies or you look broader and talk about other interventions. But if you take that broad framing, I would say we see it as the encompassing way where the countries apply incrementally or sectorally really depends on their primary efficiency question and the evidence that's available to them. There are so many similarities in processes. There are some differences in methods. Definitely, if you look at sectoral allocations, you might have to change the way you're looking. As Vaya told, as soon as you go to interventions beyond sort of precision technology, they are different empirical methods of assessment. You need to have different processes. You need to have different actors in the room. But the principles are the same. So I think we've already shifted. I think we've already won. And then I'm going to see how they argue against that. Thank you.
Thank you, Anna. No, just one clarification that the panelists were invited to present one side of the discussion, but this is just for the purpose of the debate. No, the assigned position does not reflect necessarily their personal views or the views from their institutions. So we are all working here, no?
Yeah, exactly, and those are not the views of the WHO.
That's right.
Yet.
We are playing a role, no, for sake of the debate.
Thank you so much. I think it's wonderful to hear those reflections and arguments. Really well done, I would say. So please remind the audience to keep posing your reflections, not necessarily questions, but arguments indeed for that part of the continuum. I don't like to say side because that's more opposing, and I think we are in a continuum. So please do so, because we will come back to you after we have heard the reflections from Myrene and Christoph. So Myrene, please go ahead for the more incremental part or methodological focused shaping of HTA. Thank you.
So thank you, Vaya, and thank you for the introduction to come and provide some of the, I suppose, perspectives from the other end of the continuum. My name is Maureen Ryan. I am the Director of HTA at HTA in Ireland. And I was previously the Chief Pharmacist at the National Centre for Pharmacoeconomics, and I have an academic post at Trinity. At HTA, I lead a team of about 70 analysts, and about half of them work in HTA, mostly HTA of complex or broader interventions, and then the others work in evidence synthesis to support clinical guidelines and also health policy. So we, I suppose, deploy our skills across a wide range of decision questions that need information or need evidence to support them. So I suppose in taking this viewpoint, I wanted to start with regard to the evidence that's available for us to do our work. So it's a key input for how we do what we do. So obviously, as we agree, the objective of HTA is around informing investment or disinvestment decisions. And the decision maker is looking for the best available evidence, and they want us to work to reduce the uncertainty to the greatest degree possible around the comparative analysis that we're undertaking. And if we use HTA around new interventions, we usually have health technology developers like Chris who work to develop an evidence base around clinical effectiveness and safety that meets the standards that are set out by the regulators but also by the HTA agencies to deliver a high quality evidence base. And when we work with a high quality evidence base, we can reduce that uncertainty in a comparative analysis, and then that provides an assurance to the decision maker around the decisions that they're making. But of course we use HTA for other reasons other than just to focus on single interventions. And in HTA we look at broader analysis. We look at HTAs of public health interventions like national population-based screening programs, national immunization programs. We also look at complex interventions like telemedicine or the reshaping of clinical care pathways. And one of the issues that comes up when we try to do that kind of work is to gather the appropriate and the relevant evidence. And one of the key challenges is the applicability of the evidence from other healthcare systems to our healthcare system. So each healthcare system has evolved over a long period of time, and it has a unique infrastructure which is reliant on the population distribution and demographics, the capacity and capability of the healthcare system, and also historic investment. So we quickly find that the applicability of evidence from other areas, it has limited applicability maybe when we try and apply it to a broader decision question in our own setting. So for that reason, it might point to that the use of our scarce HTA resources maybe should be deployed around those narrower decision questions where we're comparing one option maybe against another. So that's one point that I would make. Another one then relates to, I suppose, the implementation of the outputs of the HTA, HTAs that we conduct. And maybe it is appropriate that we confine HTA to those narrower decision questions where we're looking at 2 or maybe a small number of interventions, because for many of us, our healthcare systems comprise of siloed health budgets, and for that reason, a narrower decision may be more appropriate Because even as a health technology agency, we may, try and claim and try and make the case to policymakers that there's a greater benefit for the health system as a whole, regardless of which siloed budget we're talking about. But in reality, it may be very difficult to reallocate resources across siloed budgets and to achieve implementation of the best option that we have identified. Another factor I think to consider is the unique place that HTA already holds in the healthcare system. HTA is the place where we assess new technologies, where we assess new interventions. We do it in a systematic, transparent, unbiased, robust manner. We try to ensure, at least we should ensure, that it's free from other influences like political expediency, like short-term policy goals, like conflict of interest. So for that reason, I think it's really important that we maybe maintain our position as the independent evaluators of the best available evidence, because that's really important in terms of maintaining trust of decision makers, but also a key thing is to maintain the trust of patients and the public in the outputs that we produce and in the key role that we play in the health system. But I do agree that we need to evolve on a continuous basis to meet the needs of the healthcare system. And there definitely is a lot of room to evolve methods to look at those broader interventions like public health interventions, complex interventions, even medical devices that we've been trying to work with for a very long time. There's still an awful lot of room for development there, I think. And then also there's room to look at the other domains of HTA. We focus on clinical effectiveness and safety and on cost effectiveness, but maybe we need to give a more robust consideration to our other domains. So organizational domains that are really important in terms of implementation, the patient and social domains in terms of identifying what's most important to the patients, and then also the ethical domains, which are most important in terms of identifying how we can deploy interventions so that we maximize equity and dignity. So I think in terms of system shaping, it's really important that we work with the other actors like policymakers, like policy analysts, like public health experts, but that we leverage off our unique position in HTA as the independent evaluators of the best available evidence. And I think that's how we can attain the best outcomes for patients, but also for the healthcare system in terms of efficiencies and in terms of capability. And to do that then for the fixed budgets we have available to us.
Thank you, Myron. So now we move to not the least of the last, but the last reflection from Christoph. So maybe you can also introduce yourself and look.
Thank you. Christoph Gletzer. I'm heading up what we call value and access efforts for J&J. That includes everything that we talk about from evidence generation for payers, patient-relevant endpoints, real evidence, pricing, fun topic, and access policy. And I'm an active participant in the HTAi Policy Forum for many years as well. I do this for quite some time, and I had the pleasure to basically work with every healthcare system and every HTA system that is out there in the world. And reflecting on the discussion this morning, and it's always good to be the last speaker because then you can build on previous and you can also cut out of your original speech what has been already said. What it reminded me is that there is not one healthcare system out there in the world that is exactly like the other. They all have specific needs and specific nuances. And I don't like the term on high income and low income from a healthcare point of view. I like to talk more about developed healthcare system and developing healthcare systems. And I think the developing healthcare systems certainly have the specific questions that need to be addressed on how do I actually set up my healthcare infrastructure? How do I fund my healthcare system? What should I cover within my healthcare system? How do I build the infrastructure that I need? And then at some stage, they come to the question, okay, if I now have done this, what should I fund? And how do I do this? And how do I value specific treatment options that are out there? This is then where HTA comes in, which is a totally different situation as an HTA system that has been developed 30 years ago in a fully fleshed healthcare system. So now to the question on should HTA evolve, I would say it depends on where your starting base is, right? If you are one of these fully established HTA systems for 20, 30 years, the biggest change or need for change that I see is to arrive in the healthcare system and the time we are in. We are in 2025, And we learned this morning again about the massive innovation that we have seen in healthcare in the last couple of years. We have now treatment options that can deliver cure, something we had never thought about just 10 years ago. But what we still do, we evaluate these new modalities and new treatment options with the methodologies that have been developed 30 years ago. We need to adapt. As long as we see HTA bodies where it's still better, and bear with me if I use this, I'm supposed to be provocative, so I am provocative, right? There are HTA systems that value more that you die early and predictable, rather than living longer, but maybe uncertain how long. That's wrong. That needs to change. There are still healthcare systems out there, HTA bodies out there, that use a threshold which is 30 years ago. That needs to be updated, right? So depending on where you are in the development, yes, there's a need to change, but you first have to arrive in 2025. And again, I talked about the specific example on methodology already, something that concerns me a lot. In my job, I'm also sitting in the decision group that signs off final development plans, clinical trial designs, comparators. And I have increasingly challenges to explain to my R&D folks why we should include outdated, not state-of-the-art comparators in clinical trials, because it's needed for whatever healthcare system, whatever HTA system. There we need to adapt, there we need to move on, because we see, which concerns me a lot, an increasing deviation of standard of care in developed healthcare systems. In the past, we always measured this in excess, but now you can see the outcome. There are studies out there like the HONOR study on multiple myeloma in Europe that show a difference in overall survival on a societal level between healthcare system and HTA systems based on their speed of adapting new technologies. So yes, change is needed, but within your core. And once we have achieved the impact or the change in the core, then we may want to think about next steps where HTA can play an even broader role, but we need to get first to that stage of the core deliverables, addressing the unmet need, addressing the gap in treatment paradigms, and address the, what I would call, inappropriate value recognition in some of the HTA systems, which again leads to that difference in outcome for patients. It leads to broader political debates that we have right now as well, where we need to make sure that all the systems value innovation in an appropriate way, and then from there develop further. So yes of change, but first arrive in 2025.
Well done. Short and brief. So now we would like to hear some reflections from the audience. Who would like to provide us with some reflections or some examples on, maybe we can start with the health system shapers perspective. Is there anyone in the room who would like to?
Yes, there are 2 microphones, so you're invited to go to the microphones. But you can also use the app. You can send comments, examples through the app. And I would say, as there is a large proportion of Latin Americans here, if you feel more comfortable sending comments in Spanish, Carla, what do you think? I think that Carla maybe can translate those later in English to share with everybody. Ideally in English, but if you need to do it in Spanish, it's okay.
Yeah, thanks for adding that. Yes, so don't feel obliged to go to the microphone, but please feel also free to share your reflections, because we are also here to learn from you, and we are all coming from different countries and contexts and might have different roles, and I think it's very important. That's exactly the idea of this session. And it is a kind of setting the scene session, so we really would like to have a dialogue. Like I said, for us it's very important to have participation, not only us talking to you, but we really would like to hear your reflections. Whatever that reflections are, there is no right and there is no wrong, and very important to let your voices hear, because we are all in the same boat. So, but I see already a line up over there, so please could you introduce yourself and share your thoughts. Thank
Yes,
you.
hi. This is Alicia Granados. I'm currently serving in Global Medical Affairs, Rare Disease at Sanofi. But I am also co-chairing with Karen Facey and Sheila Padaya the Rare Disease Interest Group here at HTAi. And I know that rare diseases are the stress test for healthcare and the stress test for HTA. And I really would like to reflect on the keynote speaker, some of the messages that in fact are repeating in this panel. And thank you for this very, very enlightening panel session as well. Adaptiveness. I think the need to adapt, the real strategy to shaping anything is to build a capacity to adapt. For HTA, we need the strategy to adapt, and the science is evolving, and the knowledge is evolving, the biology is evolving, and we are using the old way to make priorities and assess evidence. So my call here will be, please think about it. I think we need, I really wanted Dr. Ryan approach in expanding the HTA not only to treatments but also public health interventions, revisiting the way we provide. So just insisting in the adaptiveness, and for rare, this is urgent. Thank you.
Thank you so much. Okay, Nick, please introduce yourself, and looking forward to hear your reflections.
Thank you very much. So I'm Nick Crabb, and I'm from Nice in England. So thanks to the panel, really, really interesting panel. And in terms of the two sides of the debates, I think you're both completely correct. I think we really do have to do both. So I think HTA as a sort of way of managing innovative new technologies as they come to market is totally needed. So we need to continue to do that. But we also need to be sort of system shapers. And I think it's important to think about the vehicles for that, because clinical guidelines, public health guidelines are really good vehicles to do some of those things. And it's easier for someone like NICE who develops both guidelines and does HTA. In other jurisdictions, it may be necessary to collaborate more with guideline developers. But I think that's a really good route to sort of the system shaping. And I'm hoping it's okay to go back to the keynote as well, if that's allowed, yeah. Because I thought that was really inspirational, really fantastic start to the event. The only thing I just wanted to mention was that there was a lot of focus on the non-communicable diseases, chronic non-communicable diseases, and the public health necessity there. But I also wanted to remind everybody that we've got another sort of crisis around antimicrobial resistance. So I think in the communicable disease area, there's a need for action. So I'm not suggesting crying. We won't cry. We can adopt a revolution mindset, but we do need to adopt that revolution mindset to overcoming antimicrobial resistance as well as non-communicable diseases. Thank you.
Thank you, Nick, for that plea. Indeed, very important points. I see one more. Rosella?
I'm Rosella Di Bedino from Italy, Rome. I'm speaking now with the head of the hospital-based HTA interest group that I co-chair with Iga Lipska. I interpret all your very relevant inputs from the hospital perspective. You mentioned the need to build up on the network. I would suggest to consider also the role of the hospital in those networks, because hospital at the end and more often are the real entry point of new technologies. According to a survey that we conducted 2 years ago, hospitals where HB, HTA is performed are big and have a key role in research and in the adoption of new technology. So to improve the perception of the importance of HTA, we have to pay attention also to the real entry points, to have more in-time or on-time assessment. Another point, I really appreciate that it was mentioned that we must give more relevance also to other domains as the organizational one. I want to mention that in the adopter project that it was focused on HTA, it was added also another domain that maybe now could be relevant also at a higher level, that is the strategic and political domain, where the assessment take into consideration which is the hospital policy. And last point, maybe it's provocative, we have to change the idea of technologies. It's not drug pills, but at the hospital level, we often assess the impact of these material technologies on the clinical pathway and the model of care. And we are going to assess it, not the single technology. Thanks.
Thank you so much, Rosella. So, we have many people lined up. So, Cliff?
Cliff Goodman, United States. With regard to what we can change and what we cannot change, nearly all HTA agencies are assigned a mission or a remit. We have a job to do, and often we are limited insofar as the technologies that are placed on our docket, in our inbox. So my question to the panel, which also reflects the superb plenary presentation that we heard, the keynote, is can, and if so, how, can HTA agencies provide feedback or other influence that can expand our scope accordingly to change the technologies or other challenges that come our way? Or are we locked into the remits forever and we can't provide any kind of influence thereby? I wonder if any panelists can reflect on that challenge.
Thanks, Cliff. So we at the back of the...
Yeah.
Yes,
Hi,
please.
Emmanuel Arca from Open Health. Thank you very much again for this panel. My question, I wanted to get into the role-playing a bit and be the devil's advocate in the sense that I think the argument, in my opinion, maybe it's not won yet. And the point is that there is not many healthcare professionals in the room. We don't have doctors, we don't have nurses. And when I do research, including the doctors, including the nurses, they don't even know what HTA is most of the time. How do we expand? We have some patients, and we are getting there with patient engagement. However, it's very limited, their influence on actual HTA practice. If you see the conclusion of the HTA statements, is mostly traditional clinical and economic values. Even though there is the patient engagement, it's not even mentioned in the conclusion the impact of patients. I would like to stress that indeed, in my opinion, for HTA to become a driver of change in healthcare system, it needs to be more inclusive, and maybe we need to start to change our mindset on traditional utilitarian cost-effectiveness economic assessments only. Thanks.
Thank you so much. You are a man of my heart. Yes, please.
Fleur Chandler, I'm here with the HTA Rare Diseases group. Two things that are particularly pertinent to rare diseases are the elements of pediatrics. So the evidence that you collect in a pediatric trial, 75% of rare diseases are in pediatrics, needs to be considered and interpreted differently, I believe, to your standard HTA for adults. The other element was picking up on something Dr. Ryan said, which was around looking at the different budget streams. Because again, in rare diseases, a lot of them are disabling, which then push the cost into social services. But once those budgets are aligned, then HTA concentrating solely on the medical side of things doesn't make any sense. My two questions.
Thank you so much for your reflections. So we have a last person. Yes, please come ahead and please introduce yourself.
Lea Wiedmann, London School of Hygiene and Tropical Medicine. I have a question for the panel, and it's really about the role of early career professionals in HTA. So what steps should we take to help HTA evolve from this more, reactive gatekeeper role to a more proactive architect of the healthcare system, if we are not there yet?
Great question. Thank you so much. So before we go into pose these questions to you, I would like to go to the youth panel.
Yes, Anna and Carla.
We've been getting a couple of really interesting questions and comments. One of the most pressing questions seems to be, members of the audience wants to know what the panel thinks about HTA agencies' role as a system shaper, especially given the fact that HTA agencies are bound by regulatory and legal constraints and pricing definitions. So how can you act as a system shaper?
I think that also alludes to the question that, or reflection that Cliff gave indeed, so that's great. Any other reflections from the audience?
Okay, I have a question here. Someone in the audience asked, HTA has historically responded to market demand. How can we do to balance of market and population demand in the HTA process in practice?
So I think also because we are not very, I mean, we have limited time. I would like now to go to reflections of the panel, of what you have heard. So we heard a few things from the audience, and indeed about the mandate. Can you go beyond the mandate? Is that feasible, even if it's laid down in policies? In some cases, it's laid down in regulation or in orders, for example. Is it then possible to go beyond the legal mandate? What about indeed the involvement of healthcare professionals and the role of hospitals? How do you see that also maybe in countries where the focus is mainly on priority setting at the national level in terms of defining benefit packages? I'm now looking at Anna and Saudamini. What role for maybe the regional and the municipality, the community practice in those countries? How would that fit? The silo budgeting, I think, is a great point with regard how does that relate to the role that HTA can play, or are we dependent on governmental budgets and the policies that governments set, for example, with regard to specialized budget, for example, for rare diseases or not? Or can we as HTA professionals or HTA agencies or the community play a role in shaping that? Because I think it's about how can we indeed shape either health systems or policies towards more healthcare-driven HTA that is based on needs. Maybe it's a big question, but I think that relates to all what we have heard. But please, I don't know, Christoph is looking very tempting to answer. Are you willing to start?
Yeah, all relevant questions, and I'm happy that we have the next 2 hours to try to answer all of them. But I think it's the key point is any technology, whatever it is, only actually matters when it reaches the patients, right? And this is very often then the link to the healthcare system and the hospital, or wherever it's used, community setting, community hospitals. You have to think about, as professionals in healthcare, how does it actually get to the patient, in addition to the value of the single treatment? So what else is needed in the healthcare system for the adaptation of that new technology? And this is definitely something that I think we all undervalued in the past, and that very often there were great solutions out there, but the adaptation was not there, right? And then the impact also and the benefits for the patients are delayed because it was not part of the initial thought process. Something that we also internally think much more about, what is the healthcare delivery that needs to be coming with the technology, particularly if you now think about personalized healthcare and gene testing and all of that needs to be thought about at the beginning to be successful. I think that's the point on the impact in the healthcare delivery. Patient perspective, I'm as passionate about it as you are, and many of the HTA systems I can only congratulate, because you more and more want to bring the voice of the patients in. Some are very advanced and demanding patient-relevant endpoints, which I think is the highest level of inclusion of patient relevance in decision-making. So these are the two first questions, and the other one on the mandate, and can HTA do more? I think HTA, we all need to call out where is the link to the other parts of the government, the other parts of decision-making that need to be included for us to be effective. Effective in a positive sense, or also effective in a negative sense if we see that decisions that are made by HTA bodies, after intense rigor evaluation of the evidence, they come with a recommendation, and then the next stage says, but there is no budget, or I actually undermine your value by putting a mandatory clawback on it. which is something which I never got into my head. How can we accept this as professionals in HTA, that someone else says, okay, I take 30% off your value? So this is one of these areas where we need to get out of our role. Otherwise, the impact of the technologies that we assess will not reach the patients.
Okay, thank you. Who would like to go next? Mike, yeah. Okay.
Thank you for all of those really interesting reflections, I suppose, on the comments that we've all made up here. So one of the things I just wanted to just share, I suppose, our experience in HICWA with you around the expanding the mandate, because very much we had a very narrow mandate around HTA at the very beginning. But during COVID, we were called upon with really short notice to deploy all of our evidence synthesis resources to support the public health response. And we did, a huge variety and different types of evidence synthesis and applied our skills really maybe to areas where we hadn't used them before, but leveraged off academic colleagues to support us around the quality of what we were doing. But what was, I suppose, a key thing was that evidence supported and informed the public health response, but we also then did a huge amount of work around communicating that evidence to the public. And that was seen then by the policymakers as being, and the politicians as being really important in terms of, I suppose, getting that message out there. There was an evidence behind the public health restrictions that they were proposing. And there was, with that came quite, I suppose, a very strong adherence to the public health measures. But that was the story. But the consequence for us as a HTA agency was that the policymakers realized the value of what we do, and they very much expanded the scope of what they asked us to do. So before COVID, we had less than 20 analysts. We now have 70, and we work across a very broad range of different types of interventions, particularly the public health interventions and the complex interventions, because we use that opportunity, I suppose, to demonstrate what we can achieve. So I think it is possible to expand your mandate. I mean, obviously it requires legislative changes and recognition of what your role is in that, but it is actually possible maybe to use opportunities to kind of diversify in terms of how we work. And in response to the comment from the early career researchers, I think this has been a very exciting panel. If you were at your start of your career, this has been a very exciting panel, because you can see there's such a broad range of areas where you can deploy these skills, such a broad range of decisions that these skills can be used to help inform. So if I was starting off now, I think I'd be even more excited about HTA than I am at this point in my career. So just a couple of reflections.
Thank you. Anna?
Okay, sorry. I wanted to pick up actually on some of your first comments as well, and some of your arguments about capacity and this sort of how you could absorb these changing roles, how that new mandate would come about. I think from the perspective or the countries that we work with, we're actually in a situation where HTA is quite nascent. So in fact, learning how perhaps later on this becomes quite restrictive is something that we have the opportunity to build in earlier on. So I think it really depends on the situation. And also because capacity in this area is so limited, especially where health systems are highly fragmented, again, looking at different systems, you do want to hold that capacity to answer different questions in one place. If you start to have sort of donor or development-driven architecture to consider these questions separate from government, separate from social insurance considerations, you suddenly end up with this mess. So I think the more we can say that remit, and you gave a perfect example in COVID, I was going to say at the moment in the funding crisis, we are really trying to say for HIV programs, even though the budgets have traditionally been siloed, for example, actually use that nascent HTA capacity to make your decisions and put your resources into it at the same time. So hopefully they go from 20 to 70. So I see this as a process that can evolve. So yes, I think that responds to some of the comments, and I don't want to take too much time. So.
No, thank you, Anna, and colleagues as well. There are a few very interesting questions to touch on. The big question around mandate, I think colleagues have reflected on. But one thing I would say is, I think if you look at the diversity of countries represented here from the map earlier, I'm not sure how many of those actually have, say, a legal mandate. And so there might be some flexibility for countries like ours to be able to respond in a way that our health systems require us to, whether it's for public health emergencies or for emerging challenges, as Anna mentioned. And those are opportunities that we can seize. There is, of course, the constraint in terms of capacity that some of you have also mentioned. So we might want to reach for the stars, but we need to be realistic of where we stand. And this is where the role of whether it's hospitals, stakeholders who may have traditionally not been involved in HTA at national levels, but perhaps in their own hospitals becomes even more relevant. This will again vary from context to context. And also early career researchers and someone mentioned health professionals. This is something, just to share from our experience in Thailand, we have sought to actively do that. We have tried to work with pharmacy schools, medical schools to include HTA as a module as well, because you're right, that is the future of our health system. And we hope that they can also be participating in the HTA dialogue, whether in HTA bodies or at least in the decision-making role where they understand the importance of HTA and are able to interpret the kind of evidence that is presented to them. So it's really quite an important pathway, and there may not be clear answers right now, whether it's for the mandate or the capacity, but we hope that this can be, it's maybe not a start. We, as colleagues have mentioned, we are already taking those steps, but we can try to find other ways, especially in the new reality we are in, to be able to respond. Over to you.
Thank you, Saudamini. Before we follow, we are going to ask you the same question at the beginning. So I think Denise or Amrem, I think it's okay if you return to the Slido app. We will answer the same question at the beginning, and we will say whether this plenary changed your opinion or not. I know, Christophe, you want to add something?
Just one more comment. When I was listening to you, it reminded me that the developing healthcare system, you have the pleasure to can still shape this, right? What your role is, right? By proactively going out and don't copy and paste from other countries, develop what fits to your specific situation. And I think the developed healthcare system, reflecting on the presentation this morning, you have to apply what Yoda once said, right? You have to unlearn what you have learned. If we go into a world where health is the value and we want to maintain health and prevent what we can and treat what we must, then we need to get out of this kind of closed dogmatic learning that we had in the past and be more open for change. It's a great opportunity. Looking forward to working with you.
Can we see the results, Denise or Amrem, of this second poll? And maybe when we don't have more votes, maybe we can see the results of the first one, just to see if someone changed their opinion. But while we're waiting this, I think that my brief reflections, I think we all feel that healthcare systems, public health, science are being challenged in many ways in the last years, and also HTA is being challenged. And I really feel that our role in health technology assessment is not self-evident anymore, and we still need to reflect on this every day. Of course, there is no one answer. Context is very important. It's not the same the Netherlands or Ireland or Argentina or Brazil or Thailand, but I think that we need to think about this every day, because we are entering a different era, and the role of HTA will be different in the next year. So can we compare the results of both questions? And we are running out of time. So I invite you, if you want to say something.
No, I just wanted to say that I agree with you. I think it really depends. I think the last reflections that we had is indeed that there might be huge opportunities for nascent countries or countries that are in nascent HTA to shape their role more proactively than, we do as, say, the countries that do have established HTAs, because we are indeed bound to, to some extent, to some of the requirements, because we have to do the things we need to do, right? And although I think, Myron, you said there is scope for broadening, you need to have the resources to do that as well. So, and of course, it's also the priority of your own national governments or regional or provincial governments, whether they want to invest in HTA and use HTA. But so for me, this session is very interesting because the theme is what should be the role of HTA. And I think that it can be both. It can be both proactive and sometimes it needs to be reactive. But I think we clearly showed that this continuum, there is a continuum, and depending on where you are, sometimes it might be a bit more this, and then the other way it might be a bit more of that. But I think we clearly touched upon very important points, in also from the reflections from the audience. I think that there is still a lot of work to be done for the HTA community. And I think we also should, at least if I may say so, we should take that role. We should take that more proactive role and highlight maybe where there is potential for change whenever feasible. So I would like to urge that, but I like to hear maybe your final thoughts in maybe one word or one sentence.
Thanks, Vaya, and I suppose maybe just to echo what you say, I think that we've developed a unique expertise over a long period of time at this stage, and we need to use that. We need to be looking to the future. We need to be brave, and we need to see where we can add the most value, and then work to do that.
Yeah, I think I've said what I need to say, but I just hope, I just want to second for the early career researchers. We really welcome you engaging in this, and particularly to exchange across different systems, I think, as WHO, but as other organizations. I hope this has been an example of cross-learning. It would be great if we could expand on that further.
Yes, and just building on that as well, first, it's not as dichotomous as we may have made it out to be. We hope that this is a learning experience, one, to be able to strengthen our core areas and then also be able to embrace new opportunities. We've heard this morning, I think, that we are at a very sobering period of time where we are being challenged, not just for HTA, but globally in the health sector. And it's a good opportunity for us to be able to respond with what we can. So really look forward to continuing the discussion with all of you.
Yes, I'm an optimistic realist, and I think if we continue to work together, we will move forward and we will position health where it should be positioned, and we will, as we said this morning, if we position the value of health correct and understand that health changes everything for an individual as much as for societies, and we have that as a common goal, understand where we are coming from, where the starting point is, then we will continuously evolve in sessions like this where we define what we want to do together.
I think our time is up. Huh? Okay. But I wanted to end maybe by saying that we are not crying. I think I'm full of energy to go to the next sessions. We have eaten out a few minutes of your coffee break. But the next session starts at 11:15. I would like to thank our eminent panel. So thank you so much for being with us and sharing your reflections. Also to Anna and Carla. Those are our future, I would say. So thank you so much for being on stage, and thank you all.